I'm deeply grateful that Mother Nature has turned on the air conditioning outside. So if you were out on the break, you know what I'm talking about. It's gotten colder out there, so kind of sending people in, which is great. Happy about that. Some people still coming in here. We'll get those doors closed. All right. Well, welcome back. I hope you had a good break. And let me now introduce to you our next speaker for the morning. Dr. Geeta Nayyar is a physician, technologist, and best-selling author who helps leaders leverage a human approach to innovation to achieve better health and business outcomes. A widely sought-after speaker and author of the best-selling book, Dead Wrong: Diagnosing and Treating Healthcare's Misinformation Illness. Geeta has appeared on CNBC, CNN, CBS, and numerous other media outlets, and she served as Chief Medical Officer for Salesforce, the company, and AT&T, among other executive roles. She currently serves on the board of the American Telemedicine Association and is an advisor to the American Medical Association. Please see the mobile app for Geeta's full bio, and please join me now in very warmly welcoming Dr. Geeta Nayyar.
All right, good morning, everyone. Welcome to the third day of TGI. How you feeling? Oh, that was lame. This is not the fourth day. This is the third day. One more time. All right, we're gonna have some fun today. So I like to start out with a joke. This is where you laugh. Laughter is medicine, right? So who are we if we can't laugh at ourselves? We deal with serious stuff every day, so we got to find the humor in it, right? So we're going to be talking about a couple of things today. Number one, I'm going to be talking about the context in which we are trying to do innovation. I know that you've had several talks on technology, AI, et cetera, but it's important that we step back and understand the current trends in the industry and then how we innovate in that context. Number two, I don't know if you've been hearing a lot of hype out there, but there's a lot of hype out there when we think about innovation, and we're going to talk about the hype versus the reality of how you innovate. We're going to be talking about partnerships. Lisa gave me a little bit of a hint there. So very important to think about partnerships at the board level and how we can get creative in 2025. We're going to talk about the new health-conscious consumer, largely a result of the pandemic. Number five, we're going to talk about scaling trust, how we do it in person, virtually, and at the Uber levels of Washington, D.C. And lastly, we're going to be talking about your role in shaping healthcare's future. So you with me? You ready? All right. So I don't know if you recognize me, but I want to tell you a little bit more about myself before we get into it and why I'm here and why I think you're here. This is me in the early 2000s when I was a newly minted rheumatology fellow at the George Washington University. I had a lot of pens because we were on paper at the time, right? And then the computers next to it because we were transitioning. That's how I ended up in health tech. But the long and short of it is I am the daughter of immigrant parents. Mom and dad are both from India. There was a physician shortage in rural America in the 1970s. So mom and dad were offered green cards to come and fill that gap in Beckley, West Virginia, where I was born. Mom is an internist. Dad is an ICU pulmonary critical care doc, 82, still rounds every day, saw patients all through the COVID pandemic. Right, I'm gonna clap for dad and mom, right? So I come from a medical family, and we are a family that talks about medicine and patients every day. So I want you to understand that about me personally. I want to then zoom ahead from Beckley, West Virginia to Washington, D.C., where it's the early 2000s. I'm newly Dr. Nayyar. I still kind of giggle when they call me Dr. Nayyar because it's new, right? And I get this call, and Ryan, wherever you are, this is a true story. I get a call from a family practice doctor from Nebraska. And this has nothing to do with NRC, but it was Nebraska. And it was, let's say 2, 3 in the morning. And this doc calls me. I don't know him at all. He doesn't know me. And he says, look, he's clearly panicked. He's clearly worried. He said, I have a newborn here. I don't know a rheumatologist. We don't have a rheumatologist, right? This is rural Nebraska. So I thought I'd just page the Academic Medical Center DC and see if you call me back. And like a young, naive doctor, I did, right? Who's thinking about liability? And so I said, can you present the case to me? And so he presents the case. I get the vitals, I get the story, I get the understanding of what mom's history is. And then I say, there's a rash, which is an indication possibly of lupus. And I say, can you describe the rash to me? So he does his best, because the way family practice docs describe rashes are very different from the way rheumatologists do, right? Rheumatologists were like, it's erythematous, it's macular, it's papular. Family practice doctors say, it's red. So then I say, thinking to myself, what tools do I have? I got a phone call, I got an analog phone, and I have email. So I say, can you email me a picture? I think now I got the story, I got the vitals, I got the scenario. Send me a picture. let me see what I can do with that picture, right? So I sit at the nurse's station. What do? I refresh, wait for that email, get the picture, and I'm like, this is lupus. Pathognomonic, right? This is lupus, this is neonatal lupus, which is dangerous and can be fatal if not intervened by cardiology and prepped for a pacemaker. So I call him back, I say, look, stat, cardiology consult, telemetry, and we gotta get ready for a pacemaker. We saved that baby's life with a good old-fashioned phone call and email, right? And by focusing on the patient and focusing on supporting a colleague who's trying to make healthcare better. And that is fundamentally why we're here. And that is fundamentally why I'm in technology and innovation. And if you don't lose sight of those two things, which is patients first, and how do we support the people in this room to make healthcare better collectively, you can never innovate in the wrong way. But it's hard, because there's a lot of noise out there. So I want you to remember that while you're at this crossroads, because it is a crossroads, and Lisa talked about it. We are living in a very historic time. We have lived through a global pandemic. We made mistakes, we learned, we grew, we're here. We have some new folks in charge of public health and health policy, and we don't know what that is going to change about our industry, but we sure need to be a part of those decisions. So when you think of the crossroads you're at, again, remember why you're here. You won't take the wrong path if you don't forget the purpose of being here at TGI in the first place, which is to learn, collaborate, and get better together. Number 2, burnout. Burnout has not gone away. It continues to burn on, and everyone knows that we even had a question about it, right? We can't, everything in healthcare, the rate limiting step of every one of your organizations is your staff. It's your doctors, it's your nurses, and it's the care team. And it's bad. Nearly 50% of physicians still experience burnout. 35% of all physicians are planning their 5-year exit strategy. And they blow up my LinkedIn all the way, by the way. How do I leave? How'd you do that? Da, 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 da. And it makes me sad. It makes me terribly sad. Rural health is near and dear to my heart for obvious reasons. I just told you, it's worse in rural America. For anyone in an underserved area, it's worse there. And we know that this is a lot of Americans. 1 in 5 Americans live in rural areas, and less than 10% of docs even practice in a rural area. So if you think you have it tough, it's worse in those areas. You guys with me so far? All right, so here's what I think is the biggest joke in medicine. First of all, how long have we been talking about consumer experience and patient experience? This is not the first TGI where we're having this conversation, am I right? This time we really mean it though, right? It's 2025 and we're gonna figure it out this time. But every time we have this discussion about consumer experience, we divorce it from the physician experience. How many docs in the room? How many nurses? How many clinicians we got? All right, this side of the room is my people. All right, so I expect a lot of support from you guys, right? So we don't tie them together. Perhaps this is why we're getting it wrong, right? Because here's the thing. If your staff, if your doctors, if your nurses are overworked, underpaid, generally pissed off, right, guys? How are you going to have a good consumer experience? How is a patient going to love your organization and actually want to come back, right? They're not going to. They're not going to. So we have to start understanding the rate limiting step is your care team. I don't care how much technology you have. I don't care what the scent is in the waiting room. I don't care what the music is. I don't care how boring your wallpaper is. It's not a good experience if your staff is not happy. Docs, you guys heard me? Am I right? All right. Money's tight. Money's tight everywhere. Worse in rural America, right? Who gets paid less for taking care of sicker patients. So this is a reality. How do you make $100 of work happen for, let's say, 20 bucks? This is the challenge for everyone in the room. You have to innovate. That's how. That's why innovation is important, because it drives efficiencies and it helps us stretch the dollar. Trust is a problem. Everyone seeing that? Science is not cool. Facts seem to no longer be important. But what's interesting is when you ask the consumer who they trust, still with all the noise and all the TikTok and just all the stuff, when you ask consumers who they trust when it comes to their healthcare, it's on the slide. I should have hid the slide, right? 93% of all consumers still say they trust their doctor. If they have a doctor, that's the kicker, right? So my patients, they're like, well, Dr. G said it, boom, I'm doing it, right? For the most part. Again, remember, consumer experience, physician experience. If you want to build trust in your organization, you got to tie it to your docs. Very, very important. Because here's the thing, they don't trust the system. Those same 93% of consumers that say they trust their doctor, they don't trust the quality of healthcare in America. They think it's pretty poor. 54% say it's poor, poor, poor quality. And what does that tell you in a post-pandemic world? It tells you that the consumer understands their physician is not set up for success. Their physician and themselves, therefore, are not set up for success. And they understand that the doctor is the quarterback working around this poor, dysfunctional system to take care of them. Does that resonate? Does that make sense? Are you finding that in your communities? All right, don't make me look old. You guys know New Kids on the Block, or your children. Come on. Docs, help me out. Somebody give me like a woo-woo. Yeah, we remember New Kids on the Block. All right, you're making me feel old. There are some new kids on the healthcare block, right? And again, Lisa gave us a hint about this. Why are there new kids on the healthcare block? Well, guess what? They see the dollar signs, folks, right? They see that there are trillions of dollars being spent. The consumer has no trust in the system, and clearly you don't know what you're doing. You don't know what you're doing. So big tech thinks they can solve it. The big retailers, they got this, right? Everyone remembers Walmart, right? So there are some new interesting partnerships, potential partnerships, but you need to go into it with eyes wide open. And again, remembering why you're here in the first place. Telemedicine. Look, I'm on the ATA board. I got to talk about telemedicine, right? Here's the thing. We have more than a phone call and email, and that is exciting. Telemedicine is here to stay. We have everything, texting, pictures, phone calls, video visits, the whole thing. And it's actually tied to brick and mortar institutions now. Leverage it, particularly in rural health. Figure out now the question with telemedicine is, how do we get it more sophisticated? How do we know what is the right specialty? How do we know what is the right visit, right? Chest pain, shortness of breath, not so much. But how do we take the counseling? How do we take those counseling visits? How do we work on medicine specialties? And maybe surgical has a specific use case. Now is the time to get smart with how we think about telemedicine. And remember, hybrid care is here to stay. How can it make your staff happy? How can it help them with flexibility in the schedule? So any number of opportunities with telemedicine. Cybersecurity is table stakes. Everyone remembers Change Healthcare. nearly brought the entire healthcare system to a halt. This is not even a question. This has to happen, and it needs to be locked up, buttoned up, and you can't innovate unless you've got top-notch cybersecurity plan, period. All right, the question in the room. Anyone heard of AI? Anybody? Anybody, right? So AI has been around a long time in healthcare. It's actually not new, but it has obviously gone mainstream. And it seems to have the most exciting, limitless potential that the mind can fathom. But here's the thing. There's a lot of hype and there's a lot of reality, and I want to help you find that balance, right? So the hype, I mean, you guys talked about it on the beach yesterday, right? It's going to save humanity, right? This is how we put humanity back into the profession of medicine, right? Or, I think it's so dangerous, it's just the whole sky is going to turn to fire, right? That's the hype. It seems to be these two extremes of the end-all, be-all to the devastation of everything that we know. So here's the reality. 75% today of all medical communication in your organizations is done by this good old-fashioned fax machine. Am I right? And you guys have big ones and a lot of them. Am I right? So we have to remember the reality and the data infrastructure, because a lot of this is about data, is manual, right? And it's also what the doctors like and the nurses like, because here's the thing, it works. Half of the technology in our systems right now don't work the way they're supposed to or they were intended to. So we have to acknowledge that before we try to save all of humanity, we got some basics to get organized and get together, right? Before we fly, we got to crawl, walk, and run. So how do you focus on the low-hanging fruit? What's really important to remember, and it's not provocative to say this, but it is the truth, and this is coming from a doc who still practices at the University of Miami in the most underserved communities in Little Haiti, right? You have to focus on the low-hanging fruit, and the low-hanging fruit, the lessons are actually in front of us. If we think back to the electronic health record, which was supposed to do the same thing, it was supposed to save us. It was supposed to improve documentation. It was supposed to make our doctors happy. Ha, ha, ha. Right? It was supposed to make the patient experience better. We were supposed to have all this data and analyze and share, yada, yada, yada. Remember that? Here we are, hoping AI will fix the mess we created with the EHR, right? If we look at social media, same thing. It was so cool. It was so innovative. Everyone started to have connections that they lost, right? From high school, elementary school, right? That X, right? To find everybody, right? And now what's happened? We have so much data and we know it's affecting the mental health of our children. We know that there are addictive algorithms. There are deep fakes saying you docs don't know what the heck you're talking about, right? So we have to start with the low-hanging fruit, which starts with old technologies, but the same lessons apply. What do I mean by that? I got to talk about the EHR because it's the biggest innovation we've had in medicine to date, right? And there was a lot of promise and hype attached to it. Number one, we did not involve clinical leadership in the beginning, right, docs? Nobody asked you about it till the end when they were like, hey, get all your friends to get on this, right? Convince them the technology's so good that you use it. And you were like, but I hate it, right? That was how the chief medical officer role kind of was invented. Now, how come you don't have to do that with an Apple product? You just take it out of the box and you play with it and it works. Because it's intuitive. It was a capitalistic market. It sold itself. There was no training even involved. That's how you build a good tech product. In healthcare, we just regulated it. We regulated it. If you didn't buy Epic or Cerner with the last two standing, if you didn't buy one of them, guess what? You got penalized. That's how you guys all got your EHR, right? It was so regulated and there was such a lack of clinical leadership that we now are stuck with all these highways that don't make any sense. And now we have a note that is so long, it is not meaningful in any way. Right? It's like the Encyclopedia Britannica. You know what that is. Do not make me look old. Right? The notes are so long, they're actually not meaningful. This is now a billing system, not a documentation system. We still don't share data. That was never going to happen. We knew that. Right? So there's also some things technology can't do for us. If we don't do interoperability, AI is not going to fix that. If all the data is on the fax machine, how does AI use that data to take care of patients? right? So there's still dysfunctions in healthcare. We got to get the basics right. We only can fly if we crawl, walk, run. I have one more thing to say about the EHR, and I hope I don't offend anyone, but it's simply the reality, right? And docs are going to support me on this. So here's the thing. We realized that we screwed up the EHR. We hired CMOs. We said, try to get your friends to get on that. That only went so far, right? Then we did this amazing thing where we started this entirely new business called the Scribe Service. You guys have them. You know you do, right? So what we did is we took this already cramped examining room, the physical space where your doctors see patients, right? Hospital or outpatient. And we said, let's get a manual override to the EHR. We'll get a scribe, we'll get another human in that examining room. So now there's 3 people in this very small space. And then we told our patients this: don't worry about this person. They're just here to write down everything you say. They're not a doctor, they're not a nurse. Now hit me, how much do you drink? Are you sad? Tell me about your mom and dad. What do you think that did for patient care? In an already lack of trust environment, right? And then what we also did is we had all our docs and nurses do this. The back pain, what was it again? 8 out of 10? Was it when you were standing, sitting? Which one was it, right? We took and we started this conversation talking about the doctor-patient relationship. What did we do with all the innovation we created, even the innovation we created to fix the innovation? We got right between the doctor and the patient. They went there and we went there. Docs, am I right? It was supposed to be about the patient. It was supposed to be about efficiency. It was supposed to be about saving money. We wasted a lot of money. We're hoping AI fixes it now, right? And that's what I mean about the low-hanging fruit. I talk to technologists all the time. They're already here. They're already flying. And a doc who sees patients, just fix the documentation. If you fix just documentation with AI, you will have a happy, efficient staff and patient. Docs, am I right? It's not sexy to say that, but it's the truth. Start with the simple stuff. The ambient listening technology that's out there is phenomenal. And actually, guess what? It's old school. It's the way we used to basically dictate notes. So how innovative that we went back in time to do what always worked, right? So remember that. Again, not the provocative thing to say, but it will go the distance and achieve the ROI you're responsible for as a board, right? Next, I want to believe I'm smart. Mom and dad said I was, right? I don't know everything all of the time at the bedside, right? I also don't have all of the data. I'm a rheumatologist, rare autoimmune diseases. We don't got a lot of data, right? And we extrapolate from studies and populations. So if you could give me an AI technology, any technology, that helps me with clinical decision support, I would love that. I would love that, because guess what? Instead of seeing 1 or 2 patients, I could see 5. I could see maybe 7, right? So how do you, again, go back to your staff, make your staff happy, extend the consumer experience, but do it in this way that's very thoughtful? Documentation, clinical decision support. Now I got to ask my docs here on the right corner, how many of you, and please tell the truth, how many of you went to medical school so you could do prior auth? You got to raise your hands. How many of you think your nurses went to nursing school to do prior auth? Absolutely 0. And that goes for all of your institutions. So put AI on that. Put it on the stuff your staff hates. There's a lot of stuff we hate. And it's redundant, repetitive tasks that AI is really good at. AI is good at pattern recognition, data analysis. It works 24/7. We have to sleep, right? AI is not good at empathy. Also, anyone here want to see an empathetic robot? What is that? You're missing the mark, right? It's interesting when we talk, I want to bring back to consumer experience real quick. When we talk about consumer experience, there's very little studies on consumer experience, except for Ryan, of course, who has cool data. When you ask patients, what is the leading metric that they look for to feel satisfied as a patient, and when you look at patient satisfaction scores, guess what they say? They say it's the amount of eye time that my doctor looks at me. It's not even about what you say, but it's the eye time, right? Even our spouses. I know when my husband doesn't listen to me. He's not looking at me, right? So it's the amount of time, it's the human connection. The patient is telling us, I'm coming to you for the human connection. So why are we trying to innovate that out of the interaction? Remember, the EHR put us on opposite sides, and now we're trying to get it back by innovating again. So we need to be thoughtful. Documentation, clinical decision support, prior auth, diagnostic treatments. There are a million problems to solve in those categories. Those are the low-hanging fruit. It's not the sexy thing to say, but it is the thing that will make your staff happy, your hospitals efficient, and drive the consumer experience. But they still want to see their doctor's eyeballs. So make sure that they do. Make sure that they do. Replacing doctors isn't the answer, and I had to throw this in because I don't know how many of you have been to the Consumer Electronics Show? Not too many of you, but a few of you. So at CES, and this has been for like the past few years, they have all these robots serving coffee, these AI robots, and it's really cool. They even put like scarves and hats on them and try to humanize them, right? I'm cool with that when it's a cup of coffee, right? But I don't want my baby delivered. I don't want my grandchildren delivered like that either, by the way, right? It's the wrong problem to solve, but when you go to talk to technologists, all the people that build the products, the people who built the EHR, this is what they're focused on. This is what they say. Doctors are expensive, they're burnt out, there's staff shortages, same with the nurses, right? It's the whole care team. Let's just replace those guys with some AI robots. How many people think that's a good idea or that's even happening in this lifetime? It's not. But the reason it's not is because of the consumer. Because the consumer's not going to make an appointment with Dr. G, the robot who has cool shoes. They like to see me with my cool shoes. They know the difference. The consumer is smart. They know the difference. They trust me, not a mini-me lookalike. Not with their healthcare. With their coffee? Sure. Right? So how do you keep the humanity in all this innovation? You cannot lose sight of it. Find the repetitive tasks. Find those small, painful moments that slow your staff down and innovate on those to give them their time back, to give them the eyeball space back that both the doctor wants, brings back the joy of medicine, and the consumer is raising their hand saying, hey, 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 someone pay attention to me. All right, we're going to switch gears for a second. We're going to talk about partnerships. And again, Lisa told you it was important, so I feel validated, right, by a finance person. So partnerships. We can't do it alone. We can't. If we could, we would have, right? This idea of our hospital system is going to build an AI robot, our hospital system is going to build our own EHR. Let me tell you, that ship has sailed. One, you've run out of time, and none of you have the budget to do that. That's just a reality. So you've got to start thinking about partnerships. How do you build and grow and accelerate with the right partners? And before we talk about the right partners, I want to talk about the wrong partners. Does anyone remember when Amazon, JP Morgan, Berkshire Hathaway were going to save healthcare? Anyone remember Microsoft's Health Vault? Everyone was going to put their health information in the vault, in the cloud, right? IBM Watson was going to cure cancer, guys, right? What do these bad partnerships have in common? For the most part, it's the new kids on the block that you all deny knowing, but the new kids on the healthcare block that are retailers and big tech companies that do some stuff better than we do. Number one, they got a lot of money. We don't. We're hospitals. Our margins are like 5-6%, right? They got bigger margins, no question, bigger pockets, no question. They also do actually understand the consumer experience. CVS was mentioned in last talk. They know everything about their consumers. What do? You send me a postcard once a year on my birthday that's like, Dear Jane Doe, happy birthday. You should get a mammogram, right? We don't know consumer experience. We don't do consumer experience. So we got to give that to them. But what do they not know that everyone in this room knows, better than them and always will be better than them. It's healthcare. You guys know healthcare. You've been doing this forever and you are passionate about it. That's why you're here. We talked about it in the beginning. That is why you're here. For the patients, for the doctors, to make our communities healthier, happier, and better, and make a profit doing it. It is okay. It is still a business, right? So you have to start thinking about different partnerships. We've had failures. Again, we got lessons to learn. We want to innovate like everything. Look at the lessons learned. Don't let a lesson be wasted, right? Don't let the innovation failures be wasted. So these are 3 partnerships I want to talk you through that I think are really interesting and you should watch them. But more than that, just like Lisa said, I want you to think differently. As you do your board planning in 2025, think about these 3 examples. These are just 3 because they didn't give me 6 hours to do this talk. There are many, but think about how they came together differently, but for a mutual benefit. Mutual benefit, mutual business case. So everyone knows Atrium, big hospital system. What does Atrium have? Just like you guys, patients. A lot of patients, right? They got 65 plus patients with diabetes, hypertension, CHF, you name it. They got the chronic disease patients. What is their problem? These patients keep coming back like 2 days after they get discharged, right? CHF, their salt goes up, they gain 3 pounds, and it's like, man, we could have taken care of that with a phone call, right? They now are so expensive and keep being frequent flyers. What does Best Buy have? Come on, guys, give me this one. You guys know what Best Buy has besides tech? Best Buy has the Geek Squad. Atrium will never have the Geek Squad, nor do they want to have a Geek Squad, am I right? Right? So Best Buy also has remote patient monitoring devices, not anything new or special nowadays, but Atrium reached out to Best Buy and said, look, we want to do this hospital at home program where we send patients home with a Bluetooth-enabled weight scale, pulse ox, BP cuff, you name it, right? And then we got telemedicine to support them clinically with nurses and staff, et cetera. So what happened when Atrium tried to do this without Best Buy, which of course they did the first time, right? That 65 plus patient that went home with diabetes, CHF, and hypertension, yeah, they got on the weight scale. They know what a weight scale is. But what happened to the Wi-Fi? They were calling the nurses line saying, something about like, can you tell me about my modem? What do I got to do for my modem, right? So it's not that patients don't know what a weight scale is, it's that the infrastructure in the home was a problem for this population, right? And Atrium was like, man, we don't know how to do that stuff, nor do we want to do that stuff. But Best Buy sure does. That's their whole brand, is the Geek Squad. So now they have a really interesting partnership, and from the data they have published, they're saying the numbers are great. Their patient satisfaction scores are through the roof. Their readmission rates are less than 1%, right? But look at how elegant the problem and solution was. Atrium knows patients and said, hey, this is about the infrastructure in the home. We need a partner for that. And Best Buy, nobody's going to Best Buy for their diabetes checkup, right? So Atrium gave them a whole new flood of consumers. So it was a win-win situation, and it's a very interesting partnership to keep an eye on. Number 2, Apple and NIH. I love this one. So the NIH put a grant together for researchers to say, hey, everybody has these things on their wrist, that Apple Watch, right? Could we, in fact, do a study where we looked at AFib patients who right now we blindly put on chronic blood thinners, which is both expensive and dangerous if you're playing tennis, golf, walking your dog, and you fall. So they said, what if we put an Apple Watch on AFib patients and knew in real time when they went into an arrhythmia and just put them on anticoag therapy at that moment in time? It's an interesting study, 7-year study. Data's not out yet, but I love the question. I love that we are living in a time in healthcare where we ask the question. The National Institutes of Health is asking a very provocative question of big tech. And big tech is happy to help. It's not a problem they would have thought of because they don't know healthcare. Last one, Oshi Health. I wanted to give you a startup example, and because I come from rural health, I wanted to give a rural health example. So Oshi is a startup. They primarily offer virtual GI services. Not enough gastroenterologists in the country. You all understand that. They approach primarily underserved customers to say, look, we're not going to steal your patients, because that's, of course, what the fear was. You do all the colonoscopies and endoscopies, because we obviously can't do that virtually. They're also expensive. You take the revenue. We'll do the low acuity stuff. The abdominal pain, the peptic ulcer disease just needs a script for protonics, et cetera. Right? So Oshii has now really penetrated this market, and they're showing some interesting data. They're showing that they're decreasing ER visits across the board, which isn't even the metric they were looking at necessarily. Right? So really interesting, not just from a technology standpoint, but from a business model. They actually came and said, let's do co-opetition, let's compete, but also complement in this space. You guys still with me? All right, so let's talk about the consumer of today. We are living in a post-pandemic world where everyone is interested in their health, right? Everyone is interested in their health. The wearable revolution is a really good example of this. It went from a $32 billion market pre-pandemic, 2019, to now a $72 billion market in 2023. All of you are wearing a watch, a ring, maybe tomorrow it's earrings, I really don't know. But every consumer out there wants to measure their steps, their heart rate, their mood, and their sleep. We don't even know if half of this stuff is clinically relevant yet, but the consumer said, 20, 100, 150 bucks, I'm buying that thing, right? They feel good about it. They feel like they are in charge of their health. They also, shocker, are going to social media, because most of them don't have a doctor. And even if they do, then they're looking for their doctor on social media. Most of the time, they're not finding them. And they're looking for advice. They are looking for advice. 1 in 4 adults every week are looking at social media for advice about their healthcare. They're not coming to your organization for that advice. So depending on that advice, they will seek you or your doctors out. We are living in a time where misinformation is real. It is not new. You guys know it's been around since you've been in healthcare, just like me, right? The difference is it's getting faster and farther because of innovation and technology, right? I always say misinformation is like the dull wall beige color wallpaper in the hospital in which we see patients. We know it's there. We don't pay attention to it, but we've always known it's there. Now the wallpaper is like neon pink. We can't ignore it, right? Because of social media, mis and disinformation is traveling 6 times faster than the facts, and it's going farther and faster. This has to be an issue you solve. It is very clear no one is going to solve this, and the more we ignore it, the more that we will meet those patients in the ER to clean up the mis and disinformation mess. 6 in 10 adults, even when they read stuff online or when they use now AI chatbots, they actually don't even know if it's any good, but they're still reading it in the absence of you all having a presence. So how do you build trust in that environment? How do we build trust in that kind of environment? If you do pick up a book when you leave here, I understand it's in the courtyard, read chapter 8. There is a beautiful use case where I talk through how the Cleveland Clinic did this at scale. I spend a lot of time talking with marketers about how you scale trust, and it's very simple. They do the know, like, trust model, which means consumers need to know you. You need to have a digital footprint, which now includes social media, not just the billboard, right? It's an omni-channel no. Then they have to like you. I have black hair, you have black hair, we must have something in common, right? You are female, I'm a female. You need to have staff that represent your communities. It becomes an automatic, I'll probably like that person, right? Lastly, I have to trust you. One of the coolest things that Paul Matheson, Chief Marketing Officer of Cleveland Clinic, did is he scaled trust by working with the Chief Medical Officer and the CIO and partnering with YouTube. He put together a beautiful content strategy, used his own docs, used the Chief Medical Officer to say, hey, give me the docs who speak at a 3rd grade level, simple language, can do it in 30 seconds or less, and can you get them to comb their hair, please? Right? And then he called YouTube and said, I got the best doctors in the world. Wouldn't you love for them to be the clicks? Right? And then he launched telemedicine with the CIO before anybody was doing that. And he actually made a marketing project a revenue generating project. Awesome use case. I simplified it for you. Please check out chapter 8. Lastly, We can't do trust without health policy leadership. Again, we have new management, we got a new administration, and no one is regulating this stuff. Meta just said, forget fact checking. Social media right now is regulated by the social media companies. Tomorrow they want to fact check, today they don't, right? But we are the victims, our patients are the victims. So this has to be on your radar, what public health is going to look like. What is AI regulation going to look like? We still don't know, right? And when we think about the rural communities, we think about the Black and brown communities, the biases that we have, the bad habits we have in healthcare will only be amplified by AI. They will not be fixed by AI. So these are all things our policy leaders need to know about, and you have to remind them. Lastly, we said a lot, right? We had some laughs, we had some good times, we had some bad times. Where do you focus? I'm going to bring it back to the beginning. Focus on the patients. Why are you here? You picked healthcare. Every one of us has a personal story for why we went into healthcare. Don't forget that. Pick the patients, pick your staff. The consumer experience is the physician experience. It will be two birds with one stone. Innovation's great, AI is awesome. I wish I could talk to you more about it, but the simplicities of the lessons learned from previous technologies, don't waste them. Don't make the same mistakes with an even more powerful technology. Lastly, our regulators, those in charge of healthcare, they've never known healthcare the way you do. Make sure your doctors and your nurses are going to the Hill, informing that conversation. Make sure you are all collectively working together. The answers to the problems in healthcare are in this room. No one is coming to save us. You have to do it. And you need to work together because the problem is magnanimous. Your role is the role. You got the biggest job in the house, but it is also the most exciting time to be a healthcare leader. You have more tools, more technology, and more data than anyone in your roles 30 years ago, 40 years ago, even 10 years ago. So don't waste it. Please use it. I remain a resource to you anytime. I hope you will grab a book. TGI was kind enough to support, and I'm available to answer questions now and on the break. Thank you.
Thank you, Geeta. It's been mentioned, it's been shown on the slide, but there is a table right outside that door out there that has Geeta's book. And so please pick up a copy on your way out. We don't really have time for questions at this point, but Geeta will be up here if you want to come up. You can ask her anything. I'm sure she'd be happy to meet you at the break or whatever as well. So let's thank Geeta one more time.
Thank you. Thank you.
We're going to take a short break until 11:15. Please return then. Until then, have a great break.